What up, fam? Are they on? Because it says live, right?
It says live.
Yeah, Z-Pack. Y'all know this guy. This is my brother-in-law. Come on in before we talk. Come on in. I want to see some more live viewers than zero. We're going to talk about a lot of cool stuff today. We got three people.
Okay.
Yeah, 10.
Well, it's the day before Thanksgiving.
It is. They're already eating murdered bird. Makes me want to go vegan Thanksgiving with all the carnage. 21. Come on. We're not going to start talking until y'all... Look at that. There we are. Let's show us... we're looking on the main computer here, too. Let's open that up. There it goes. Turn that off so we don't get feedback. Now I can read comments there. Hi, Chloe. Hi, Christy. Hi, Jen. Hi, Lisa. Hi, Lynn. Look at, they're all here, man.
Awesome.
Everybody's here. Let's do this. Dr. James Riddell, clinical professor of infectious diseases at the University of Michigan in Ann Arbor, or Ann Isle, as I like to call it. Nobody calls it that. Is here visiting for Thanksgiving with the family. Mm-hmm. And so I pulled him into the Z office and I said, I'm going to force you to do what I force you to do every time, which is talk about stuff you're really knowledgeable about, which is infectious diseases. And we were talking earlier, and I was like, well, you want to talk about shingles? You want to talk about varicella? Because these are things I care about. I'm like, vaccines. He's like, yeah, that's all fine and dandy. How about endocarditis and IV drug use? Why were you interested in this?
Yeah, so it's been a problem in our institution for a while. We noticed that our patients with endocarditis, the mortality was a lot higher than what we would expect when we look back. And so one of our fellows, actually, Samuel Delati, formed a working group to try to take better care of our patients.
So working groups sound dumb to me. Like it sounds like something that like some administrator would be like, well, we're just going to go ahead and form a working group on healthcare violence and nothing will happen. What is a working group?
Yeah, so how this works is once a week for an hour, we have a group of people that includes infectious diseases specialists, cardiothoracic surgeons, cardiologists, neurologists, an addiction specialist, and we all get in a room and we discuss these complicated cases of endocarditis, figure out how to take care of them best.
Well, so this is where it got my interest. When you said addiction specialist, I'm like, we're talking about endocarditis. And then I remembered, in the 90s when I was training at San Francisco General, most of our endocarditis was intravenous drug abusers who ended up introducing bacteria into their bloodstream, infecting their valve, and nearly dying, or being cured only to go back out and re-inject, re-misuse, and sometimes with a central line. Mm-hmm. So let's back up for a second. How is it that happens? What's the mechanism?
So there can be contamination anywhere along the process of intravenous drug use. So that could go anywhere from the manufacturing of the product itself. So if we're talking about heroin, for example, the product can be contaminated. But more often it's in the administration part, in preparation of the product when it's injected. And so a lot of times people mix it with tap water, which is contaminated with bacteria. From there, often it's filtered through cotton. Cotton, I always used to think of it as sort of this sterile product, but it's not. It's a natural substance. It comes from a plant, and it's contaminated. And so, for example, Aspergillus spores can be on cotton. And then when you, of course, inject those into the bloodstream, that causes problems. You can see endophthalmitis, even rarely endocarditis related to that.
Do you get a lot so what kind of organisms do you say? You mentioned Aspergillus. Yeah. Do you get a lot of sort of anaerobes and different things like that? So spit-related stuff?
Yeah, so it's a lot of, it depends on the contamination. So Aspergillus, I bring it up mostly because I'd seen a few cases that's actually pretty rare.
Yeah.
But it's
by the way, you got to speak up a little. People are like, give him your mic.
Okay.
You see, not everyone's an extrovert like me. Some people are actually smart and soft-spoken.
Anyway, Aspergillus is rare. The more likely organisms would be actually oral bugs, because a lot of times people will lick the needle.
That's what I remember,
when they inject. And so a lot of oral bugs. We see water bugs like Pseudomonas. We see, and really anything that's on the skin. And so Staph aureus, another real common organism. So anywhere along the way, you can have contamination.
Right. And which valve is preferentially affected when you're intravenous drug injecting?
Yeah, good question. So what happens and part of the reason why you might ask, well, why would you filter, the product? Well, there can be little particulates that are in the product that's injected. And even though you filter it, they don't all get filtered out, obviously. And so what can happen is those little particulates will damage the right side of the heart. So we're talking about the tricuspid valve most often. And so often what you'll see is damage to the tricuspid valve done by the particulates. And then once you introduce bacteria, it will latch on to that damaged heart valve. So right-sided endocarditis is what we get most often see.
And that makes sense because you're injecting in a vein. The
Correct.
vein is feeding into the right side of the heart, right atrium, tricuspid, right ventricle.
Right.
And so, and this is a, sort of, when we were medical students, that was the first thing they pimped us on is,
Yep.
okay, right-sided endocarditis, guy lives in the Mission, this and that is going on. What do you think it is? And if you didn't say there was an intravenous drug question that you asked, then you were hazed and humiliated, which was our way at UCSF. So you got right-sided endocarditis, these different bugs you're talking about. How do you start the diagnosis process, like when you're called? Yeah.
Right. And so if we suspect a case, it's blood cultures are the key. So you get several sets of blood cultures. And, when you're thinking about endocarditis, it's very important to obtain those blood cultures before you start antibiotics.
Yeah, listen up, ER. How many times it's like, well, we went ahead and started some empiric vancomycin, and then we went ahead and drew the cultures. It's like,
infectious diseases doctors hate that.
they hate that, yeah.
Because we want to know what the organism is so that we can pick the right antibiotic. So drawing 3 sets of blood cultures before antibiotics are started if you're suspecting endocarditis is very important.
Right. And we got to remember, like, sometimes blood cultures are harder to do than you think. I was just at an organization where they kind of let go all their phlebotomists to save money. Wow. And so who was drawing the blood cultures in the emergency department? The ER nurses. Oof. And it was brutal because you'd have a ton, and then you have all these algorithms like, oh, you got to get cultures first, then do the antibiotics. Right, and then if we don't do it within so many hours in a pneumonia, then you fail a core measure. So again, staffing matters and process matters. So, okay, so you get your blood cultures, and then you find out, okay, the guy's got maybe a fever. What are some other symptoms that you get?
So fever, evidence of emboli. So you can, if there's bacteria on the right side of the heart, you can see septic emboli going to the lungs. And so you might see lung nodules and a chest x-ray. It might look actually like pneumonia. So that's interesting you bring up pneumonia because sometimes it can look for all the world like pneumonia, but it's actually endocarditis. So you have to be really thoughtful. And I think that's why it's also important to get that history of IV drug use because people often don't ask that question.
Yeah, people, especially medical students in particular, they're scared to ask or they just don't see the relevance.
Right.
And then somebody with a pneumonia, they have fevers, there's other stuff that's maybe it's a little bit subacute. And you're like, what? It's just a pneumonia.
You could potentially miss it.
And not only that, but then you treat the pneumonia. Maybe you suppress some of the symptoms for a while. They go home, come back with a ring abscess or some. What are the complications of untreated endocarditis?
Yeah. So if it's on the right side, again, lung abscess, would be a complication. On the left side of the heart, which you can also get with IV drug use. So we're talking about the aortic valve and mitral valve. That's the most dangerous kind because then you can have emboli, little pieces of the vegetation that forms on the heart valve. It can flip off into the arterial system. So we're talking about strokes. They could embolize any organ in the body. And that's how, when you talk about diagnoses, you can often see peripheral emboli, like in the hands and feet, little spider, or little
the splinter hemorrhages, Janeway lesions,
Osler nodes,
Osler nodes.
Right, you learned about in medical school.
And never see
some
in
of
real
those.
life.
Although some of those actually are immunological phenomenon. Interesting.
That's right. They're not the emboli itself. It's the immune response to this infection.
Exactly.
Yeah.
So those are some of the things, but the most feared complications are stroke because that can be permanent. And particularly a hemorrhagic stroke because then that plays into the difficulties you have with when you're talking about treatment.
Right. Now, one of the things, so we were talking about earlier, endocarditis is fascinating. You can get it from other things. I mean, dental work, poor dentition with stuff. What are some other random causes of endocarditis?
So anything that causes bacteremia, really.
Right, bacteria in the blood.
Particularly with an organism that likes to stick to heart valves. And so what are those organisms? Staph aureus. And so if you have Staph aureus bacteremia, it could be from hospitals too. So if you have a contaminated central venous catheter with staph, for example, that could stick to the heart valve. Or urinary tract infection, for example, with Enterococcus, and you have bacteremia from that. So there's lots of different things.
Well, having a damaged valve is a risk as well.
Yes, that's right. Damaged valve, congenital valve abnormality, so bicuspid
aortic valve.
Yep, that's a big one. But as we get older, Are we getting older?
No, we're young. Look at me. No wrinkles, brother.
As one gets older, you can get sclerosis of the heart valve, and so that puts you at risk as well.
Got it. Now, we started talking about intravenous drug use because, again, when I was a student, and I didn't see it as much as Stanford because we didn't have as much than we had at our county hospital, Santa Clara Valley, where we did see it.
Yeah.
But I'd never seen as much as I had in San Francisco General in the 90s. Now, but what happened with you was a different pattern.
Mm-hmm.
So you weren't seeing a lot of that.
No, so University of Michigan, I've been there for almost 20 years now, and we didn't see a whole lot of intravenous drug use early on. But here recently, and really I'm talking just the last few years, we've seen a lot more people coming in with complications related to intravenous drug use. And endocarditis, as we've been discussing, is a big one. And so that creates all kinds of difficult management issues.
So I remember, and this is where there's transition in the discussion here. I remember as a student, I was a sub-I. And at San Francisco General, as a sub-I, they let us do everything. We could write orders. We could, they treat us like a doctor. It was one of the greatest rotations and experiences of my life because it convinced me that doing medicine, particularly hospital medicine, was who I was.
Sure. It's your calling.
It's my calling, and having that the freedom and the trust to do the right thing. And it's funny because who saved my butt when I didn't know what I was doing? It wasn't often the residents or the attending. It was the pharmacist who was like 10 trillion units of penicillin, probably not the right dose. It was the nurses who were like, you know what? Maybe when you're drawing that blood culture, because we had to draw the blood cultures on, AIDS patients in the middle of the night who were spiking temperatures because they didn't have phlebotomists. So what I remember is we would have these IV drug users. They would come in with endocarditis. That I remember them vividly. One of them was intubated in the unit, and they did a weaning trial. They started to wean him off. He woke up, self-extubated, pulled out the tube, had a central line, walked out of the hospital.
Wow.
Eloped, as we say in the business. And we never heard from him again. And the chances are that he died using that central line. So the complications of intravenous drug use are often fatal. And what you even noticed in your own organization was that you were having a very high mortality rate.
Yeah, and so particularly with our endocarditis cases, we were noticing a high mortality rate. So again, getting back to our new fellow, he looked at the data and said, hey, can we improve our outcomes with our endocarditis cases? So what we formed was this working group.
Who's your fellow?
So Sammy Eldolati is his name.
You're famous. We made you hot, Sammy.
Kudos to Sammy. He's done a whole lot of really hard work on this, and it's really been great. So he's formed this group. And what was interesting about it is Sammy said, I want to form this group. And we all looked at him and said, what? Are you crazy? Are we allowed to do that? Is that possible? Don't we have to get permission or something? And Sammy's like, no, we're doing this, and I've scheduled it for next week.
That's a go-getter, man.
Okay.
Yeah. And you're like, that's not how this works. That's not how any of this works.
And what was so awesome is that the people showed up, everybody was interested, and we've been helping take care of patients since. And it's really actually worked great.
That's amazing. So this multidisciplinary working group.
Multidisciplinary group. And so we all sit down, we think about what's best for these patients. And so one of the issues that's come up is, well, how do we help the folks with IV drug use? Because our cardiac surgeon, Dr. Deeb, he said to us, look, we can fix their heart valve problem if we need to operate on them. You can treat them with antibiotics. But if the root problem, the intravenous drug use, if that's not addressed, we're not going to heal this. We're not going to help this person in the long run, because if they use again, which often is the case, if they're not getting help, then they're just back in the same situation they are now. And so how can we address that?
Yeah, and so that's the thing. You're not treating the root cause.
Right.
The root cause is the addiction and the intravenous drug misuse.
Right.
And so it's a hamster wheel. And there's a thing, you guys even had a policy, right? We'll operate on you once.
Yeah.
But what happens if you come back?
Exactly. And so there's a lot of institutions where the policy of the CT surgeon is, if you use intravenous drugs, you develop endocarditis, they replace your heart valve, that's it. They will not operate on you again in the future. Well, what happens when that person comes in? it becomes a real ethical dilemma. And actually, there's a whole sort of medical literature on this dilemma.
What to do.
And a lot of ethics boards, get involved in these cases. And it's very difficult. It's not a simple thing. So the easy answer would be like, well, you heartless, jerk, why aren't you operating on this person? They need your help.
Right.
But on the other hand, again, it's this hamster wheel, and do we
and a resource issue,
right? And are we really helping this person, or are we just perpetuating?
Because they're going to go right back, maybe with your PICC line.
Right.
So you're going to discharge somebody. You don't want to keep them in the hospital the whole time because it's expensive. It's a dangerous place and get infections. Yet they need 6 to 8 weeks of intravenous antibiotics, so they have maybe a PICC line or a central line. Wow, what do you do?
Exactly. And so what we have done traditionally up until now is most of these patients, we will keep them in the hospital or try to keep them in the hospital till they complete their antibiotic course. And so that takes up an acute care bed for 8 weeks.
And it creates a rock garden for the residents.
Or 6 weeks, right. And so it doesn't work well for anybody, really.
Right.
The residents, the house staff don't like it, the hospital doesn't like it, and the patients don't like it. I mean, a patient who wants to be sitting in a hospital and they're not getting treated for their root cause issue, which is intravenous drug addiction, substance addiction. And so,
which probably began with prescription drug abuse,
often
increasingly so.
Often.
So in other words, this is another manifestation of the opioid epidemic. Now we're seeing heroin use increasing.
Well, what's happening is, so in some ways, we're victims of our own success, right? So we are not prescribing opioids as much as we used to.
So what happens?
So when I've seen this time and time again, patients I'll ask, well, how did you get involved with IV drugs? Well, I was taking OxyContin for back pain. My doctor stopped prescribing it, and so I had to find something. Now I'm using heroin, and now I have this infection related. So it's a real issue.
Yeah. And who are we blaming? You can moralize about it a lot, but the bottom line is you need an effective strategy to manage it. So what were you guys thinking you could do? Because they're going to go out with that PICC line if you send them out, and they're going to inject through it.
There's a good chance they could.
Yeah.
So that's the fear.
Yeah.
And it's just the complications are can very very easily occur that way. And so that's why we have not done that. There are different approaches to that. There are patient contracts and things like that. But traditionally, we've been very nervous and somebody who's actively using, and so usually we keep them in the hospital. But again, Sammy had come up, thought to himself, well, is there a better way, than keeping somebody in an acute care bed, and can we treat their addiction? And so what we're trying to get started actually in our institution is first an inpatient addiction medicine consultation service. Inpatient. So the person is in the hospital, they're getting their intravenous antibiotic. Can you have a consultant come by, a psychiatry addiction medicine consultant, start working on, okay, what's our plan? What's our plan going to be for Suboxone or methadone for managing the addiction issue? But that's only sort of the first step, right?
Right.
Because then what happens after that?
Right.
And so the other thing we're going to propose is to set up some sort of almost like a rehabilitation inpatient unit where folks could go to receive their intravenous antibiotic. They could also receive addiction medicine services and continue that. And then once you've completed your antibiotic, then continue into outpatient addiction medicine treatment.
So you have them anyways, and people are asking in the comments, wait, can't you just give them PICC line as an outpatient? I'm a PICC nurse is what we do. The problem is they're going to potentially misuse that line to inject and be right back or dead. And so, what a temptation. You're suffering with addiction, and now you have open access to your veins. You don't have to find a vein. You don't have to skin pop. You can go right in. Right. So what Jamie is saying is, you're going to keep them there to give them their course of antibiotics. Why not start to treat their addiction with medical management? So aggressive addiction management by trained professionals who are specialists in this, including potentially Suboxone, and then continue it as an outpatient. Now, my first question is, where are the resources to do this?
Yeah, that's the tough one. And so we're going to have to, address that clearly. Are there state funds, we're investigating that, or is there some sort of grant, mechanism we could work through? Because clearly, I think every state is dealing with this problem.
Right. Every single one. Yeah.
Everyone. And so, can we come up with some sort of a system where we can help these people with assistance through government funding, for example?
Right. No, that's perfect. Now I'm going to take a little detour for a second here because Tom Heineber, our producer, just wrote in here as a comment. He says, "Yo, Z, I had the baby. Spoiler alert. We need to talk about lactation consultants when I get back. LOL, these people are the worst. Sorry in advance if you're one of the good ones." Oh, first of all, congratulations. Kennedy Heineber was born at 7 pounds, 14 ounces, and 20 inches yesterday. Z-Pack. Let's give Tom a hand. Tom and Danielle. Danielle, NICU nurse, and Tom's wife, his vastly better half. And yes, the lactation Nazis will torture you, Tom Heineber. They will torture you. So prepare.
Part of the process.
I know. This is the thing. This is how I got over it. I started lactating. And by delivering direct man milk to the child,
they say it's healthier.
It's vastly, it's all colostrum. So, okay, back to the addiction endocarditis piece. So, what's your sort of next step in making this happen? Sammy and you are going to work on this with the working group, or how are you going to do it?
So we already have the endocarditis working group. We've been doing this now for several months, and actually we've had great outcomes with that.
Tell me about that. Tell me about that.
Yeah, so we've actually, of the patients we've discussed in this group, the patients have gotten operated on in a timely manner. We've had great communication with our surgical colleagues and our cardiology colleagues, and we've been able to provide service much more quickly and efficiently than we used to, such that our mortality rate for the patients we've seen has been 0. Which is, kind of blows our mind a little bit.
That's fantastic, because it was higher before.
It was much higher than that before. And so we're already seeing improvements. Now, this is only over a period of what we're like into 10 months now. We've been doing this for almost a year. So we're still collecting data, and we're going to analyze this to compare in previous, years how all shakes out. But so far, it looks like it's actually really providing a great service for our patients.
This is great. What I love is that you're actually studying it because it's an academic facility, University of Michigan. And so you're saying, okay, if we're going to do this, we better have data that it actually does anything.
Exactly.
Because there is a cost to getting groups together to talk about stuff.
Yep.
There's the annoyance factor. There's a time factor. There's the lost RVUs and productivity, because you can't click boxes if you're sitting in a meeting. But the truth is, what we've lost with the EHR, we gain back when we meet together.
Yeah.
So face to face with the CT surgeon, the addiction guy, the ID guy, the neurologist, the internist, the hospitalist, all together going, okay, well, how can we better manage endocarditis, which is a multidisciplinary issue?
Yeah, it's multidisciplinary. It's a very complex sort of set of issues you end up having to deal with. It's not only the medical issues, but it's also, again,
psychosocial issues.
Social issues, again, you get into the addiction issues.
And then the case manager, social worker, having them in those meetings is probably key.
Yes.
Because they have to arrange all this stuff.
That's right.
Yeah.
Yep. And the other thing are physician extenders. And so, among the CT surgeons, there's a fantastic physician assistant who sees all these patients. And so we're involving, again, the whole team together.
And the PAs are doing a lot of that frontline work.
They do.
Especially in the surgical side, for real, like you said. Yeah. How about nurses? Are they involved in the discussion at all?
Yeah, so far we have not had nursing representatives, but that's a great point. We should.
They're so understaffed. I don't know how they have time to even attend. Yeah. No, got it. But I think having the full team involved in how to manage these guys. So we talked so far about endocarditis, about how it's often right-sided in people with intravenous drug abuse, how we're seeing it increasingly in places where we hadn't seen it because people are now being sort of transitioned from opioids to intravenous drug use involuntarily many times. And the question is, how can we better treat it? How can we prevent it by improving drug abuse and addiction issues? How can we manage it interdisciplinary with a component of rehab and addiction treatment?
Right.
Preferably starting inpatient. And is your experience, you're going to find out because you don't know yet, is your experience that these patients want to change?
Oh, absolutely. I mean, the patients, they are crying out for addiction services of some sort. They're not available. They're very difficult to access. And so that has been a real problem. So I think the patients, yes, they want it, they need it, they understand it's a problem, they need the services. And so we just need to figure out how to provide them.
So, and to me, there's nothing more motivating than nearly dying.
That's right. Yeah.
You feel terrible. Yep. You're poked full of lines, and even though these are intravenous drug users, they hate needles. They hate it when other people. It's a lack of control.
Well, especially when you've been through a huge operation. So, say you need a heart valve operation.
Yeah.
You know that's huge. There's a huge amount of recovery involved there. So you're right. That this is the time. You know, when if there was ever a time
to intervene, they're motivated.
This would be the time to do it. So how can we make that happen?
So what I want to hear from you guys, Z-Pack, in the comments or in private messages to me is your group, academic group, doing something similar? Is there something that we can learn from each other in implementation as Jamie's group moves forward with this idea, and his working group, and the idea that we can start to treat addiction and endocarditis as a target of opportunity now? Like, we can actually save their life long term and change their life and improve this terrible problem. Assuming we can bring the resources to bear, collaborate, and improve our processes. This is the magic of academic medicine, actually. Apart from being an ivory tower of a bunch of self-righteous, pompous a-holes.
We got plenty of those.
Plenty of those. Other than that, this is the fertile ground to grow these great ideas. And the other thing I want you guys to tell me is what you'd like me to talk about with Jamie, Dr. Riddell, while he's here in town for the next couple days with us in Las Vegas. Give us your topics, and we'll see if we can cajole him into doing another show. In the meantime, the call to action is this. Hit share, leave a comment, press the little like button, because that gives Facebook the juice so that more eyes can be on what Jamie's talking about. And then if you really like what we do, become a supporter of the show. Click the little button. It's $4.99 a month. I don't think I told you about this. $4.99 a month, these guys can subscribe, and then we do private talks. But more importantly, we take their resources and we grow the show, we grow the movement, and we buy a little Kennedy, Tom Heineberg's new baby, a Benz, because she needs a little Benz, a little Mercedes. All right, guys, let's congratulate Tom. Let's thank Dr. Riddell, and have a great and safe Thanksgiving. Hopefully you're not working.
Don't eat romaine lettuce.
What? Okay. Hit me with that real quick. So the CDC comes out. I put a meme up today which basically said, why is it that when the CDC says don't eat romaine, everyone's like, hey man, you're right. And then they say, but you should get vaccinated. And they're like, those guys are Illuminati. Like, it's a double standard. So what's the basis? Do you know what's going on?
It's E. coli contamination.
E. coli.
And what's interesting about this recall is that it seems like they're recalling all romaine lettuce.
Yeah, they're just like, whoop.
And I think it has to do with the fact that they weren't able to identify exactly which batches it was or where it was coming from. It's a multi-state outbreak. So yeah, it's a little scary.
It's a little scary, and it's a little depressing for the romaine lettuce industry.
Yeah, no kidding.
Because you're throwing out, these guys are probably really good, and then there's one guy who used contaminated canal water or something, or night soil, is like throwing feces at their E. coli, at their E. coli delivery vehicle, aka romaine lettuce, and now they're throwing everything out. So, all right, well, we'll talk more about that as details emerge. And you know what's funny is we had just bought a thing on romaine because your wife had a cool recipe. So Margaret and I came back from the store with all this romaine.
Started eating it raw.
Out of the box. Then she pulls up like Apple News and she's like, what? And all this romaine. But anyways, these are first world problems, people. In the third world, we just eat the E. coli, become immune to it, and suck it the hell up.
Feed the microbiome.
Feed it. And we out. Peace.